Hello, I'm Dr. Hagop Kantarjian from the Leukemia Department at MD Anderson Cancer Center. It is my honor and pleasure to interview Dr. Nicholas Short from the Leukemia Department at MD Anderson. What we're going to do is address older patients with acute lymphocytic leukemia. So as you know, Nick, the tradition of treatment in ALL for the past 6 decades has been intensive chemotherapy for 3 years. And that has been very successful in the younger patients who can afford that kind of a treatment, and also in adults up to the age of 60 years. But what we struggle with are the patients who are older than 60 who cannot tolerate the intensive chemotherapy. So we're going to divide them into 2 groups, the Philadelphia positive ALL and then the other ALLs, including pre-B and T-cell ALL. Let's start with Philadelphia positive ALL. So if you have a patient today who presents to you over the age of 60, Philadelphia positive ALL, what would be your considered or ideal approach for these patients?
So our approach now really for patients of all ages or adult patients of all ages are chemotherapy-free regimens. So at MD Anderson, we really piloted these chemotherapy-free regimens specifically with blinatumomab and ponatinib. There's other data from other groups with blinatumomab and dasatinib. We'll treat the patients the same whether they're 20 years of age or 70 or 80. I think the challenge with, for example, blinatumomab and ponatinib is just making sure as patients get older, they are more likely to have contraindications to ponatinib. So sometimes we do have to adjust the TKI for those patients. But generally speaking, many of our patients don't have, if they don't have significant cardiovascular risk factors or they're well controlled, we treat them with these chemotherapy-free regimens. We actually initially started these studies in the older patients because we were anxious about treating younger patients with chemotherapy-free regimens, and then we found these excellent results with very high rates of MRD negativity, durable remissions with chemotherapy-free regimens in the older patients, and then expanded it to the younger population as well. So right now we're able to treat Philadelphia chromosome positive ALL of all ages with largely chemotherapy-free approaches. There still are some challenges there. We have a concern about CNS relapses, for example. We've increased the number of doses of intrathecal chemotherapy, initially from 12 to 15 to overcome that. We still struggle with some patients with high white count. White count over 70,000 increases the risk of relapse, specifically CNS relapses. So we've tried to introduce high-dose methotrexate and cytarabine. Now, for older patients, it depends, certainly if they're over 70, even many patients over 60, it can be challenging to treat those patients with high-dose methotrexate or cytarabine. So I think for some high-risk patients who are older, we can still consider those for patients for CAR T-cell consolidation, for example. But now we have excellent results across the age spectrum where we see the similar outcomes for younger and older patients with chemotherapy-free regimens, and importantly, without stem cell transplant.
So which patients would you still send to transplant?
I don't have any patient that would come in on day one where I would say I would want to send this patient to transplant.
How about during treatment?
Yeah, it's extremely rare that this happens. So, for example, in the blinatumomab study, we've only transplanted 2 patients. In one of those patients, they had persistent PCR for BCR-ABL. This was before when we really understood this concept of multilineage pH positive ALL. We didn't have clonoSEQ on them, and we sent them. In retrospect, maybe that patient wouldn't have needed transplant. I know another one of the patients, we couldn't track the clonoSEQ, so we're anxious about that patient, so we send them to transplant. But otherwise, newly diagnosed patients, we see excellent MRD results, specifically with NGS MRD, and we really don't send patients to transplant in the frontline setting. Now, if some of the patient relapses, we can at least consider them for transplant once we get them to remission, but oftentimes we can actually salvage a patient and consolidate them with CAR T cells without even needing transplant in first salvage.
So you talked about 2 methodologies of MRD. One is the PCR, which is what we all use today, and the other one is the NGS MRD clonoSEQ. In the context of Philadelphia positive ALL, can you tell us what you see in terms of concordance, discrepancy, and what to do if they are discrepant?
Yeah, so I think we're learning more about this concept of multilineage pH positive ALL. So these are the patients who will have an excellent NGS MRD response. It could be PCR for immunoglobulin receptors, PCR NGS, but we'll still have persistent usually low level PCR for BCR-ABL. We actually see that in up to 25% of patients, depending on your cutoff, somewhere between 15 to 25% of patients. Now, in the past, before clonoSEQ, we would say that this was perhaps a molecular failure. We would say that this patient was high risk, wasn't having good MRD clearance, and therefore needs, stem cell transplant. Now we understand that these patients actually have similar outcomes to those patients who are PCR negative, as long as they're NGS MRD negative. So while we look at the PCR for BCR-ABL, I think it's still somewhat informative. We're really making our big treatment decisions, our risk stratification, based on NGS MRD. The one way that the PCR for BCR-ABL impacts our treatment approach, I would say, is the decision to potentially discontinue the TKI. So right now, our approach is at least 5 years of TKI maintenance after completing blinatumomab and ponatinib. Then for patients who have a good NGS MRD response, as well as are PCR negative, we can consider, after a discussion with the patient, stopping the TKI on that patient after 5 years of maintenance. I don't think that we are ready to, and I probably don't think we should stop the TKI for patients who have even low-level PCR, because we've seen anecdotally some of those patients, if you stop the TKI, you can see a rapid increase in the PCR. Now, they can stay NGS MRD negative, but I would be worried about that patient's risk for relapse. So those are patients where we would just continue indefinite TKI.
I see a lot of the studies being designed with TKI maintenance for 2 years, particularly in children, but also in some adult Philadelphia positive ALL studies. Is that something we should follow, or do you think we should use it for longer? And is there a scenario like chronic myeloid leukemia where a particular duration of NGS PCR negativity will encourage you to stop therapy because you have some data that they do not relapse?
We've known in the past that patients with Ph-positive ALL can have later relapses. So I am anxious, at least in our adult population, to stop the TKI that early. I think that there are probably many patients that will be cured by 2 years, and it's probably safe for many patients. But I feel more comfortable with the approach to give the TKI for longer for non-transplanted patients.
How much is longer in your estimate?
I mean, again, we've been doing 5 years. I mean, if you look at the historical data about even late relapses in Ph-positive ALL, they're more likely to have relapses than compared to Ph-negative B-cell ALL that may happen in between year 3 and 5. Yes, they can have occasionally very late relapses, but it's still unusual for the relapses to occur after year 5. So I think 5 years is a reasonable time period to continue the TKI, and then consider stopping, like we do for patients with CML who've had a really good deep response for a long period of time. And I think importantly, when we stop the TKI for those patients, we should be monitoring them like we do TFR in CML. So I do very frequent, both PCR, but most importantly, clonoSEQ, NGS MRD, really monthly or every other month for the first year, just to make sure we don't see any MRD recurrence in that.
On the blood?
I think for those patients, I think blood is probably fine. But bone marrow is a little bit more sensitive. It's about 1 log more sensitive. So we're still gaining experience with TFR. So my personal approach has been to alternate bone marrow and blood in a situation like that.
One last question about Philadelphia positive ALL. So ponatinib is toxic, even though it's very effective. What are your thoughts on alternatives to that? Would you choose dasatinib, or would you choose a 3rd generation TKI to replace ponatinib in this setting?
I think on clinical trials, I'm excited about using these other, newer TKIs, such as combinations with asciminib or, olverembatinib, for example, but this is in a clinical trial. Outside of a clinical trial, I think the data that we have is with the 2nd generation TKI with dasatinib, which I think shows very good data, right? We have 4-year survival rate of over 80% in the DIALBA study, but the concern is the development of T315I mutations. So I think until the data mature with these other TKIs, and in the case of olverembatinib, it needs to be commercially available in the future to do this outside of a trial, I would err on the side of using dasatinib. But we try to still give ponatinib if at all possible, but of course for those patients where it's not safe, usually dasatinib would be our go-to.